Two, one, start.
A very good morning to all of you. So welcome again in class of Department of Urology, SMS Medical College, Jaipur. So today we have a session on radionuclides in urology. So this will be presented by our resident, Dr. Abhishek, and would be moderated by our faculty, Dr. Ajay Raj. So I would request Abhishek to kindly share his presentation.
Good morning, everyone. Thank you, sir. Hi. Good morning, everyone. The topic for seminar is radionuclides in urology. Starting from the history, George D. Hevesy discovered the radionuclides, and the John Lawrence is father of the nuclear medicine. The first application in patients of an artificial radionuclide was when he used phosphorus 32 to treat the leukemia. Isotopes. Isotopes have unstable nuclear configuration. They achieve greater stability by decay or disintegration to a more stable form. So in attempting to reach stability by emitting radiations, they are called radionuclides or radioisotopes. The radionuclides can be photon emitting, used for imaging, positron emitting. So by radiotracer studies, they provide useful and often valuable functional information that is not easily available from other methods. They are associated with lower absorbed radiation dose and significant lower morbidity than with contrast-assisted procedures. Scintigraphy does not damage the kidney and has no lingering toxicity and is free from allergic reactions. It is non-invasive, has minimal risk, minimal discomfort, and allows determination of the function of the kidney. So the radionuclide is injected and the radiation emitted are detected by the gamma camera and the images are obtained. So this is a gamma camera, the PET-CT machine, the radiation generator, the dose calibrator, and the pharmaceuticals. Radionuclides for imaging, the desirable characteristics are minimum particulate emission. Primary photon energy should be between 50 to 500 kilo electron volt. Physical T-half should be more than the time required to prepare the material. The effective T-half should be more than the examination time. There should be low toxicity, stability or near stability of the product. It provides the functional and anatomical information. It is more organ or tissue specific than CT or whole body scans. So the radiopharmaceuticals is equals to radionuclides plus a pharmaceutical. So pharmaceuticals can be DTPA, MAG3, EC, MDP, DMSA, FDP, PSMA, EDTMP, and MIBG. And the radionuclides are technetium M99, M means metastable, 18F, lutetium, gallium, and samarium. Technetium 99M, it fulfills many criteria of ideal radionuclide. There is no particulate emission. It has half-life of 6 hours and a predominant 148 kilo electron volt photon conversion. It is used in more than 70% of nuclear imaging processes. The techniques can be 2D scintigraphy, 3D SPECT, or a hybrid of those. The indications are for renal perfusion and function, the renal clearance measurements, urinary tract obstruction, furosemide renal scan, renovascular hypertension, captopril renal scan, infection, pre-surgical quantification, for example, for the before nephrectomy, renal transplantation, and congenital anomalies or masses, the renal morphology scan. So this is an overview of renal radiopharmaceuticals. Depending on the renal handling, they can be divided into handled by glomerular filtration, tubular secretion, or tubular retention. The pharmaceuticals handled by renal handling is EDTA and DTPA. By tubular secretion is OIH, MAG3, and EC. And tubular retention is DMSA and GH. These substances handled by glomerular filtration are used to calculate the GFR. Those handled by tubular secretion are used to calculate effective renal plasma flow. And those which are retained in tubules are used for cortical imaging. So the glomerular agents are DTPA, EDTA, and iodine iothalamate. Technetium 99 DTPA, though inulin clearance remains the gold standard to measure the GFR, but it is expensive, time consuming, and requires a steady state plasma concentration and accurate and time during collection. It is recommended agent for GFR measurement. 5 to 10% plasma protein binding is seen in DTPA, so it tends to underestimate the GFR, but it is clinically insignificant. The peak renal activity is achieved after 3 to 4 minutes, and 95% is filtered within 4 hours. The extraction fraction of technetium 99 DTP is approximately 20%. For this reason, it is not useful for imaging in patients with impaired renal functions. It can be used up to serum creatinine of 3 milligram per deciliter. In such cases, agents with higher extraction efficiency, such as MAC3, are more appropriate. And chromium EDTA, which may provide more accurate GFR, but they cannot be used for imaging because of its longer half-life and high gamma camera emission. Then there are tubular secreting agents secreted by renal tubules, MAC3 and EC. They have the MAC3 has 70 to 90% protein binding, 89% tubular secretion, and 11% glomerular filtration. The extraction fraction is 40 to 50%. So it provides a high target to background ratio, good image quality, and more accurate numerical values, particularly when the kidney function is low and immature. The dose is 5 to 10 millicurie IV. EC scan, it is secreted in PCT, proximal convoluted tubules. The protein binding is 50%, and the clearance is 69 to 85% of OAH. The creatinine up to 7 milligram per deciliter. If the creatinine is up to 7 milligram per deciliter, this can be used. Then there are cortical binding agents, DMSA and GHA. Coming to DMSA, it can be used in pyelonephritis, infarct, scars, anomalies. It has 75% protein binding in 6 hours, and 5 to 20% is excreted in 2 hours, and 40 to 50% cortical localization. Images are at 2 and 4 hours. So basic renal scan, the procedure is, first of all, patient preparation. The patient must be well hydrated. We give 5 to 10 ml per kg of the water. We can also measure urine specific gravity to check the hydration. It should be less than 1.015. Patient is asked to void before injection and then void at the end of the study. So acquisition, the supine position is preferred. In the flow phase, there is 2 to 3 seconds per frame for 1 minute. In dynamic phase, the images are at 15 to 30 seconds per frame for 20 to 30 minutes, and the display is at 1 to 3 minutes per frame. We obtain a 30 to 60 second image over the injection site at the end of the study. If infiltration more than 0.5% dose, we do not report the clearance. We obtain a post-void supine image of the kidney at the end of the study. Radionuclide renal evaluation. We can go for functional imaging, renography, quantification of renal function, and the anatomical imaging. Functional imaging, the perfusion imaging, there is evaluation of renal blood flow and functions of the native kidney, posterior projection in the native kidney and anterior projection in transplanted kidney. 10 to 20 millicurie of radiopharmaceutical is injected in antecubital vein. Imaging is usually begun as soon as bolus is seen in abdominal aorta. Subsequent images are taken every 1 to 5 seconds. In normal renal blood flow, by 3 seconds, aorta is fully visualized. By 5 to 6 seconds, both kidneys are seen. Maximal kidney activity is reached in 30 to 60 seconds. At the end of perfusion sequence, the functional imaging, DTP or MAC3 are the dynamic or sequential static at 3 to 5 minutes in technetium 99. DTP or MAC3 are then obtained over 20 to 30 minutes. Evaluation is almost similar to an IVP with anatomy, position, symmetry, and adequacy of function and collecting system patency. With technetium 99, MAC3 maximum parenchyma activity is seen at 3 to 5 minutes. Activity in collecting system and bladder by 4 to 8 minutes. This is a normal DTP scan. Then renography. It is a time activity curve, the graphical representation of uptake and excretion of the radiopharmaceutical. Information is displayed from the time of injection to about 20 to 30 minutes. The renogram phases, there are 3 phases, the flow phase, functional phase, and the clearance phase. The flow phase is the vascular phase. It lasts for 30 to 60 seconds, and the maximum activity is seen at 4 to 6 seconds after the peak aortic activity. The functional phase is the parenchymal uptake phase, the maximum activity at 3 to 5 minutes. Then uptake at 2 to 3 minutes is used for the split function. And the clearance phase is the washout phase. There is no activity after 30 minutes. This is a diagram showing flow phase, functional phase, and the clearance phase. So data obtained from the renogram, the time to peak cortical activity at 3 to 5 minutes. The half excretion time is calculated. It is the time for half of the peak activity to be cleared from the kidney. Normally is 8 to 12 minutes. The cortical activity at 20 minutes divided by peak activity is less than 0.3 on Mach 3 renogram. So relative or split function, it is the contribution of each kidney to the total function. Normal is 50-50 to 56-44. Borderline is 57 to 43 to 59-40. And it is abnormal if it is more than 40 and less than 60 on the other side. So this is a diagram showing kidneys with intermediate function of 57-43 and 59-41. This is the scan showing perfusion and the function. We can see the diuretic is given and the diuretic time is at 10 minutes. The function of the left kidney is less. It is around 5 ml per minute, and on the right it is 50 ml per minute. There is no clearance. And in the above perfusion phase, the white line is showing the aorta, and pink is right kidney and blue is the left kidney. The function in the left kidney is left in the right. Then quantification of renal function, GFR and EPRF measurements. There are two methods: plasma sample-based clearance method. The amount of activity remaining in the blood at the prefix time is the measurement of activity not yet cleared. So indirectly, it is a measure of the activity already cleared. It is more accurate, but it requires determination of levels in plasma and sometimes in the urine. Then there are camera-based clearances. The counts are obtained from the syringe before injection and subsequently over kidneys after the injection. There is no need for urine and blood collection, and it is a sufficiently reliable method. Then anatomical or cortical imaging, we use DMSA or GH. The images obtained at 2 to 4 hours of the injection, posterior, right posterior, oblique, left oblique view. The normal finding is smooth contour of the smooth contour with the homogeneous activity, the less uptake in medulla and no activity in the PCS. Then furosemide or diuretic renal scan. The obstructive uropathy may lead to the obstructive nephropathy. So the indications of diuretic renal scans are to evaluate the functional significance of the hydronephrosis and to determine the need of the surgery. If there is obstructive hydronephrosis, it will require surgery. But if there is non-obstructive hydronephrosis, the medical treatment of follow-up may be okay. Then we can use it for monitor the effect of the therapy. Principle is in hydronephrosis, there is tracer pulling in the dilated renal pelvis, and the furosemide induces the increased urine flow. If there is obstruction, it will not wash out. And if it is only dilated and non-obstructive, it will wash out. We can quantitate the ratio of washout by using the T-half. So the protocol is almost the same. There we do oral hydration prior to the study. The NS is given at 15 ml per kg over 13 minutes, 15 minutes prior to injection and continued during the study at 200 ml per kg. Bladder catheterization is required in children or if there is DJ stent in situ. Technetium-99 Mach 3 scan is the agent of choice in children with limited function because it has high target to background ratio, good image quality, and more accurate numerical values. Then prerequisite is there should be some residual function to respond. Diuretics are given 20 to 30 minutes after the radiotracer injection. Imaging is done for 20 to 30 minutes. Post-micturition image is obtained. Functional images, renal time or activity curve, washout half time are calculated. Symmetric uptake and good washout is by definition not obstructed. So diuretic renal scan, the T-half is the time required for 50% tracer to leave the dilated unit. That is the time required for activity to fall to 50% of the peak. T-half is normally if it is less than 10 minutes, obstructed if it is more than 20 minutes, and indeterminate if it is 10 to 20 minutes. These are the O'Reilly curves. The type 1 is the normal. In type 2, there is obstruction. And in type 3A, it is hypotonic. After giving diuretic, there is washout. And in 3B, even after giving the diuretic, there is less washout. In type 4, there is delayed compensation. There are two peaks, also known as Holmesy sign. Scintigraphic evaluation of the hydronephrosis. The image is showing non-obstructive hydronephrosis of the left kidney. The arrow indicates a brisk response to the intravenous diuretic. Then this is showing obstructive hydronephrosis of the right kidney. The arrow indicating a no response to the intravenous diuretic. Then F-15 diuretic. The Lasix is injected. The Lasix is injected 15 minutes before the radiopharmaceutical. So the rationale is that the kidney is in maximum diuresis and under maximal stress. Some equivocals will become clearly positive, some clearly negative. Renal cortical scintigraphy, the indication is to determine involvement of upper tract in acute UTI, to detect cortical scarring and for follow-up post-treatment. Gold standard is technetium DMS scan. The radiotracer is uptaken only by the functioning mass. Pyelonephritis impairs the tubular uptake of the radiotracer. These areas appear as unexposed or underexposed. Persisting areas on follow-up indicates irreversible renal damage or scarring. The cold effect can mean acute or chronic pyelonephritis, cysts, tumors, infarct, or a trauma. They are not always due to infection, and all TMS defects are not necessarily scars. 2-year-old girl with recurrent fever, we can see the photopenic area. Then renal cortical scintigraphy, we can look for congenital anomalies, agenesis, ectopy, fusion, polycystic disease, multicystic disease, and pseudotumors. This is a normal DMS scan showing good cortex of the both kidneys. This is a horseshoe kidney. Then renal agenesis. Then patient with recurrent UTI, the ectopic left kidney with multiple photopenic areas, multiple scars. For renal transplant scintigraphy, the surgical complications, urinary leak. In urinary leak, there is initial photopenic defect, which increases with progressive radiotracer accumulation. And in abscess, there is washout of the initial photopenic defect. So they say there is persistent of the initial photopenic defect. And in a lymphocyte, there is initial defect, which is almost equal to the background activity in the delayed phase. So this can be used for renal transplant scintigraphy. Then direct radionuclide cystogram, DRCG, it is used to detect reflux. MCUG is mostly preferred than DRCG in regular practice. We fill the bladder with DDP and acquire the scan. Grading is depending on the visualization of the tract. It can be on DRNC grade 1, 2, and 3. Grade 1 if it is confined to the ureter. Grade 2 if it is up to the renal pelvis. And 3 if there is diffusely dilated system. The use in prostate, we can use as scintigraphy, PET-CT, or as therapy. In scintigraphy, we can go for bone scan, PET-CT based on FDG, PSMA, choline, and in therapy, lutetium, PSMA, EDTM, and radium.
For example, MDPA, just skip by saying what is MDPA, was this last in the exam?
Sir, scintigraphy, in the scintigraphy, we use technetium MDP bone scan. In PET-CT, we use 18 FFDG and gallium PSMA, 11 carbon choline, 18 fluorine choline, fluciclovine, and sodium F bone scan. In therapy, we can go for 177 lutetium PSMA, 177 lutetium EDTMP, 153 samarium EDTMP, and radium 223. So radio tracers for prostate imaging, the FDA approved ones are sodium fluoride. It is used for imaging of the bone to define areas of altered osteogenic activity. The FDG, it is used for assessment of abnormal glucose metabolism. Choline, imaging of men with suspected cancer recurrence, or if there is non-informative bone scintigraphy, CT or MRI. Then FACBC is also FDA approved. It is used for imaging in men with suspected prostate cancer recurrence based on elevated PSA level after the prior treatment. Then bone scan, technetium 99 MDP is injected IV and the scan is done after 3 hours. It is used to detect the osteoblastic lesions. More active the bone turnover, more radioactive material will be seen. The sensitivity is good 99% and specificity is only 65%. The false positive lesions can be infections, degenerative changes, and the lytic lesions cannot be detected, such as fractures or metabolic lesions. 18F PET-CT improves the sensitivity, improves the spatial resolution, and the lytic lesions are better visualized, but it is not really done due to higher cost and higher radiation. This is a bone scan showing metastasis in the pelvis, increased activity in the pelvis on the left side. PSMA, it is a type 2 transmembrane protein. It is expressed in 100 to 1,000-fold times more in prostate cancer cells than in normal cells. There are two parts, external and the internal. The external epitope is radio-labeled with gallium or fluorine, also present in jejunal cells, salivary cells, and the Schwann cells. These scans are not affected by biopsy artifacts, which is an advantage over MP-MRI. So the PET-CT is better than 18F FDG and gallium PSMA. FDG is based on GLUT receptors, can be used for aggressive tumors, lesion more than 7, castrate-resistant extensive disease. It is not used for indolent tumors. It can be used for metastatic evaluation and monitoring response. The PSMA expression can be helpful in pre-radical prostatectomy before the biopsy, prostatitis, BPH, or carcinoma for biochemical recurrence and metastatic evaluation. So this is the CT image showing vertebral metastasis. Then PET FDG image also showing the vertebral uptake, but the orientation is not good. So we combine the PET CT with CT with the PET FDG, and we can see the lesion. Similarly, we can see the bony uptake in this scan. So used for palliation of bone cancer in cancer patients. There are radiopharmaceuticals available for reduction of metastatic bone pain, and the duration of response is from few weeks to a few months. The commercially available ones are sodium phosphate, strontium 89 chloride, and samarium 153. Now alpha emitters, these are all beta emitters. Now alpha emitters are also used. For example, radiant 223. Sodium phosphate, the advantage is it is oral and less expensive. Strontium 89, it is used in castration-resistant prostate cancer bone pain. Samarium, the adverse reaction is myelotoxicity, and the initial 48 to 72 hour increase in the pain known as flare phenomena. Radium 223 not only palliates bone pain, but also increases survival by three months based on ALSY-MPCA trial, and FDA approved for MCRPC with bone pain. This main side effect is diarrhea because it is excreted by the small bowel. The treatment of prostate cancer, lutetium PSMA can be used for castration-resistant prostate cancers, and it is a beta therapy. The most common side effect is xerostomia. Then lutetium and samarium bone pain palliation therapy. EDTMP gets absorbed in the bone metastasis. Bone metastases are well distinguished on MDP bone scans. Only the bone metastasis distinguished on MDP bone scan are eligible for this therapy. So these are not much distinguished. So this patient is not eligible for this therapy. And here the metastases are well distinguished. So this therapy can be given. The use in adrenal 18F FDG PET scan is gold standard for pheochromocytoma, except in MEN2 MIBG. The iodine MIBG scan can be used for hypersecreting recurrent or metastatic pheochromocytomas. The iodine cholesterol can be used for adenomas and MIBG therapy. MIBG scintigraphy, it is used for detection of the ectopic pheochromocytoma and is a gold standard. Then uro-onco other than the prostate, we can use in RCC, bladder cancer, testicular tumors, and the penile cancer. The MDP, in these, the MDP bone scan can be used to detect skeletal metastases. The DTP scan can be used for functional and drainage. DMSA for the split function, and FDG for staging metastatic evaluation and the recurrence. For kidney cancer FDG, PET has highest sensitivity for papillary RCC type 2 with metastasis. The Zerentuximab targets the CAIX carbonic anhydrase 9. Carbonic anhydrase 9 is universally expressed by clear cell RCC and the technetium system EB. It binds with high mitochondrial content in oncocytoma and parathyroid adenoma. So this is image showing differentiation of a localized RCC from a benign renal oncocytoma using system EB scan. So in a systemically scan, the renal, there is uptake in the renal oncocytoma, but there is no uptake in the clear cell RCC. So it can also be used for testicular imaging in torsion, epididymoorchitis, or abscess. In early torsion, there is cold defect on both flow and delayed phase. In abscess, there is a hot defect in the flow phase and cold in the delayed phase. And in infection, there is hot in the flow phase and the delayed also hot. So this is epididymoorchitis, and in testicular torsion, there is cold defect. The radionuclides can also be used in male infertility. It can be used for penile scintigraphy by using RBC labeled with technetium 99M to evaluate the penile blood flow for erectile dysfunction and radiological evaluation of priapism. So coming to conclusion, the role of nuclear medicine in investigation of renal parenchymal function and upper urinary tract abnormalities, the radiation burden is low. They do not require sedation or specific patient preparation. They are easy to perform, and the knowledge of renal pathophysiology and recognition of limitation and technical pitfalls are essential. Thank you.
Thank you, Abhishek. I think radionuclide imaging is one of the subjects which probably be overlooked many times. So it's good that the residents, trainees must know about the various radionuclides used in urology, how they are being used, and indications, and the other things. So, Nachiket, Sanjay, if you want to say anything, residents and faculty, if you don't have any question, any query.
Need to interview with the T half that he was stating.
Yeah.
I think.
Yeah. T half of?
T half of DTPA scan, you said that it was less than 10 to 20.
No,
And but
T half is 6 hours with DTPS technician line.
he said less than 10 and
Is a protein binding.
T half after diuretic, you said that the time period is less than 10 to 20, equivocal, and more than 20 it is obstructed. But now the universal value that is taken is 15 minutes and 15 to 22 minutes and more than 22 minutes. And I'd also like to add that the reason why these have been taken is that why intermediate is in between 15 to 20, if you see the T half of Lasix, then this is roughly around 18 minutes, right? Then you should have told about if it's intermediate, then what do you do? A note about Whittaker's would have been important. Fluoroscopic Whittaker's would have been important. Why Whittaker's is not done? Because the proof in the pudding is, difficulty is finding those which have intermediate T half, right? So you should have, told about Whittaker's is very important. Asked inside the exam also. What you do inside those cases which have intermediate function and you do not know whether they are obstructed or not, right? So I think that is important. Then again, why do you take a T minus 10 to T minus 15 protocol? Again, the answer is because Lasix has a T half of roughly around 18 minutes. So you want to prime the kidney primarily. I mean, you can also give it half an hour before or 45 minutes, but that's not the answer. The answer is all depends upon the pharmacodynamics of furosemide, right? So this is important. And then you didn't tell about the region of interest. Why do you mark these kidneys? This is because there's going to be background activity in everything. The liver also, the spleen also. So that's why you have to mark the region of interest. What the region of interest, where the scintigraphy should be picked up. Right. So that's why what you do in grossly hydronephrosis, there were things that I think that you should have discussed.
Yeah, I think, these are very important points that you should know about imaging. So as he mentioned in the last about the background noise and the target, actually the imaging of the target level. So usually there is a subtraction of the target with the background noise which is done. And then there is something called attenuation. So all these are important terms when this imaging is done and how you measure the actual GFR and the effective renal plasma flow. Yes. And yes, nowadays they say that the obstruction is about 15 to 22 is considered as equivocal, and less than 15 would be obstructive, normal, and more than 22 obstructive. And what you need to do if it is equivocal. So one of the tests is Whittaker's test, and which is a slightly invasive test. So that's why it's not usually done. And then he told about the diuretic. It's important. Why you give F minus 15? Because the peak activity of the diuretic is in 15 to 20 minutes. So when you are giving F minus 15, the patient is already in maximal diuresis. So these patients who are on equivocal range, they would have either go clear positive or clear negative. So that is why F minus 15 is used in patients where there is an equivocal response. Right.
A point in history also.
Yeah.
O'Reilly, he was a urologist.
Okay.
Or O'Reilly, he was a urologist. He used to work in Newcastle. So when the TTPA scans all these O'Reilly curves, he was a consultant urologist in Newcastle on time. So उसने ना ये दिया था, he studied his patients and then he started giving, and his paper was well tampered diuretic venogram in obstructive urethra. This was the paper. So
yeah. So very important information from the history. I also am very interested in the history also. So Nachi, let's go ahead.
see, Dr. O'Reilly, he was a urologist and he used to work in England in Newcastle. And Newcastle is a city on Tyne. That is a river. So that's why the whole is Newcastle on Tyne. So O'Reilly, inside his patients, he started studying these curves and he gave these O'Reilly curves. And his paper, if you look at the full name of the paper was Well-Tempered Diuretic Renogram for Obstruction of the Kidneys. This was the name of the paper that came out. Then he gave all the do's and don'ts about diuretic renogram, ki hydration kitna dena hai, what you just told about the hydration when the laces is given. It's important to catheterize, what the importance of catheterization is. So because this is a contribution by a urologist, so you should know this also.
Yeah, very, very important. Good. Or really, you must know those people who have discovered things and a little bit about them. When was it discovered? Who were they? Very important information. So you told about who actually discovered radionuclide, George D. Hevesy, who is known as the father of nuclear medicine, is John Lawrence, and the year 1936, right? So these things are very interesting, and as a urologist, we must know. And so if nobody has anything to suggest or any query, then we may just give a small brief. You come here, a brief note on the whole topic, and then we will start with our MCQs. Right? Yes, please. So we all know radionuclide agents are important in urology. We know about a little bit of the history and what are radioisotopes. That is also very important. So radioisotopes are agents which have unstable nuclear configuration. So there is a radioisotope generator where they make this radioisotopes, and they would tend to achieve stability by emitting or decaying radiation, right? So they tend to achieve stability by emitting radiation. So it may be either a photon emitting or a positron emitting. So typically the radioisotope that we use, technetium-99M, is photon emitting. And then we have positron emitting like carbon and others, nitrogen. All these are carbon emitting, positron emitting. So what are radiopharmaceuticals? That's important. Usually they are one radioisotope is combined with some pharmaceutical agent, right? So that is called radiopharmaceutical. So usually what we get, technetium-99M, which is a pharmaceutical agent, and the radioisotope is the DMSA, DTPA, and others, right? So indications as I described, it is used for imaging, basically. Either it's for function of the kidneys to either know the GFR or the effective renal plasma flow. So when we talk about effective renal plasma flow, usually GFR is 1/3 of the effective renal plasma flow. So whenever you get an effective renal plasma flow, if you want to deduce GFR, it is usually 1/3. And then indications include for anatomical imaging, and then we have to find out obstruction, either POJ obstruction, obstructive megaureters, ectopic ureterocele, etc. For infections like pyelonephritis and chronic pyelonephritis, for vesico-ureteric reflux. Usually follow up these patients of vesico-ureteric reflux can be done by this scintigraphy, renal scan. And then anatomical imaging for congenital abnormalities. That is, again, important. So all these are the indications. And then we have, you must also know about how it is done, right? It's very important to know to hydrate the patient properly. Usually you give normal saline during infusion, during this scanning, and then you must ask the patient to void before the procedure and after the procedure. That is again important because the radiation, whatever is that, should come out of the body. And then it's good to know about the renal function. Why this is DTPA is not used after 3 mg/cell because of its extraction fraction value. So it is the extraction ratio is around 20%. That is why it's not as effective when it goes above 3 mg/cell. So in azotemia, you have to be very careful in doing a DTPA renal scan, and it may give some kind of fallacious results. Something about the diuretic response. So diuretic response can be blunted sometimes or may not be very clear or equivocal in patients. One is a gross hydronephrosis. So if there's a gross hydronephrosis, there would be difficult to know exactly whether this is obstructive or non-obstructive. Similarly, azotemia, if the creatinine value is very high, it's very difficult to know. Then if the hydration is not proper, then again, the patient may not have a proper diuretic response. Infants, because the kidneys are still not properly developed, the diuretic response may not be that correct. So these things are important to understand. And then the uses in therapy. Therapy, we all know there are various agents which can be used for therapy. The phosphorus, as you said, was the first agent to be used for leukemia, the radionuclide agent. And then recently, the latest is the lutetium. Lutetium, that is a term called theranostics. When the radionuclide agents are used for therapy, so this is called theranostics. And we know that lutetium, when combined with this PSMA and gallium-67, is being used for therapy in patients of metastatic prostate cancer, particularly when they have bone metastasis and they have avid lesions on PSMA PET-CT. I think these things are important. And then you must know that various techniques. So usually what you get is a CT scan, scintigraphy, 2D scintigraphy. And sometimes with the computer reconstruction, they can make a 3D reconstruction. So this is called 3D SPECT. And then there's a hybrid where you have a SPECT CT or a PET CT. So this is the hybrid for technique of the nuclear scintigraphy. I think that's good enough. If you have any query, let me know. Otherwise, we'll go for the MCQs. MCQs. Right. So as you all know, we end up our session with MCQs. So MCQs number 1. When performing technetium 99M MAG3 renography, the relative function of each kidney is determined by measuring the area under the TAC between what 2 time points post-injection? Is it 1 to 3, 3 to 5, 5 to 10, 10 to 15, 15 to 20? Yes?
3 to 5 minutes.
So it is 1 to 3 minutes. 1 to 3 minutes, right? So dynamic imaging is performed in 2 phases. In the first phase, known as perfusion phase, renal plasma flow to each individual and renal unit is measured and compared with the flow time with the aorta. So that's why you get an aortic curve also, right? Activity should be detected in the region of interest. That's what Nachiket said about ROT, the region of ROI rather. With several seconds of detection in the aorta, the relative function of each kidney is determined by measuring the area under the TAC between 1 to 3 minutes post-injection. So you must understand the various phases. First is the vascular phase, which comes in the aorta, it comes within 1 to 3 seconds. In the kidney, it comes at 5 to 6 seconds. That's the vascular phase. And then you have the parenchymal phase. And then you have the washout phase or the excretion phase. So which radiotracer is ideally suited for imaging renal scarring? So DTPA, MAC3, DMSA, citrate, sulfur colloid. So DMSA, we all know that there are three types of agents. The one is excreted by glomerular filtration, the other is by tubular secretion, and the third is the cortical binding. So DMSA is the cortical binding, which can give you anatomical imaging. So we can know the various scars, we can know the various congenital anomalies by this DMSA scan. So it gives your anatomical imaging of the organ. And DTPA, we all know, gives a function GFR plus whether this is obstructive or not. And MAC3 is a better agent when we consider azotemia. So if the patient has more than 3, you go for MAC3 scan rather than DTPA scan, right? Because the extraction ratio is around 50%, where DTPA is around 20% only. So DMSA. So 2-deoxy-D-fluorodiglucose or 18-FDG is phosphorylated by which glycolytic enzyme traffic it inside the metabolically active cells? Hexokinase, glucokinase, phosphofructokinase, pyruvate kinase, and phosphoglucose isomerase. So hexokinase, right? So this is being 18-FDG is being metabolized by hexokinase. Which urologic malignancy is poorly imaged with 18F-FDG PET? Bladder cancer, penile cancer, prostate cancer, renal cell carcinoma, and seminomatous germ cell tumor.
Prostate cancer.
Prostate. We all know we have a PSMA PET-CT, which is so 18-FDG is not that good for prostate cancer because there is an increased glucose metabolism in the prostate, right? So that is why the FDG is not a good pharmaceutical for prostate cancer. So FDG is taken up by the malignant cells, which commonly shunt energy production towards anaerobic metabolism, a phenomenon referred to as the Warburg effect. A number of genitourinary malignancies, including urothelial carcinoma, renal, squamous cell, testicular germ cells, can be successfully imaged with 18F-FDG PET. Prostate cancer is unique in that it does not show increased levels of glycolysis and therefore is poorly visualized with 18-FDG PET.
Can FDG PET be done in diabetic? There is a
Why?
relative contraindication of
The glucose has to be normal before FDG.
So
it has to be properly controlled.
controlled before doing a 18-FDG. So a good point by Dr. Neeraj. Yes.
As a matter, relative state of fasting only 8 to 12 hours before an FDG.
Okay.
The patient is asked to fast because they want minimal glucose activity inside the surrounding body. So it's essential to get a glucose and
Right.
also fast for 8 to 12 hours with proper hydration before.
So an important point made by Nachiket that before PET-CT it should be fasting. So because the cells should not have glucose, and that is why the 8 to 12 hours of fasting is important before PET-CT.
Ask the patient to fast. In fact, they ask him to have plenty of fluid.
That is why, because this is not 18-FDG, that is PSMA PET. That's right. So the very important point. Which protein is highly expressed by clear cell carcinoma, but not other renal tumor types, and serves as a target for molecular imaging of this malignancy? GLUT1, PSMA, GPR, CA9, and ASCT2. No, for renal cell carcinoma.
PSMA.
Which protein is highly expressed? No. So this is carbonic anhydrase 9. So CA9 is the enzyme which is there, highly expressed in clear cell carcinoma.
Carbonic anhydrase 9.
Yeah.
Carbonic anhydrase.
Wait, CA9, carbonic anhydrase 9 is right. So this cell surface protein is nearly universally expressed by clear cell, but not other renal tumors. So that is why they can actually tell you whether this is clear cell carcinoma or a non-clear cell carcinoma. Right. So technetium 99M DMSA undergoes renal clearance and is endocytosed by cells of which part of the nephron? Glomerulus, proximal tubule, distal tubule, ascending limb of loop of Henle, and collecting duct. Which part of the nephron? Proximal tubule. Okay. And this is usually a cortical binding agent. It retains there, right? Unless others are excreted, right? Like your DTP is excreted by the by glomerular filtration. And the MAG3 and EC is actually by tubular secretion. And this is an agent which remains there in the proximal tubule, and it's known as cortical binding agent. So proximal tubule, DMSA is cleared from the plasma primarily by GFR. Once within the lumen of the renal tubules, it undergoes receptor-mediated endocytosis by the proximal tubular cells, and the receptors responsible for endocytosis are migalin and cubilin. So these the endocytose cells help in retaining that radiopharmaceutical, and it acts as a cortical binding agent. So 18F-FDG PET is recommended for which application in men with testicular cancer? Initial cancer staging of patients of post-orchiectomy tumor markers, initial cancer staging of patients with negative post-orchiectomy markers, post-chemotherapy imaging in a residual retroperitoneal mass with a seminomatous germ cell, in a non-seminomatous germ cell, and post-treatment surveillance. So we all know testicular tumors are usually not, we don't give PET-CT. They are not a very good imaging study for testicular tumors, but the only indication for PET-CT is C, post-chemotherapy imaging of a residual retroperitoneal mass in men with a seminomatous germ cell tumor. Right. So,
rapidly dividing.
huh?
The seminomatous tumors are rapidly dividing.
Yes.
So they will consume glucose more compared to non-seminomatous.
Right.
So that is why they will be evident in seminomatous and not evident inside non-seminomatous.
Okay.
Because they are the seminomatous tumors, they are those which have got the best rate of duplication, multiplication, mitotic activity, and
Okay.
divide jada.
So comparatively, because germ cell tumors are actually tumors which have increased division, increased because they have increased, because they are germ cell, they have a increased division, increased, but probably seminomatous have a more than non-seminomatous. That's why.
Respond to chemo and radio also.
Right.
Division jada.
The seminomatous respond to more chemotherapy and radiotherapy. Fine. So any other question? If nobody has any question and nobody in the from faculty has any suggestion to make, then we will wind up the session. Dr. Ajay, would you like to say anything? Yes, no. So I will ask the moderator to kindly wind up.
3 milligram आपने जो बोला था is very important. They asked in my exam also. What is the cutoff?
Thank you, Abhishek, for wonderful presentation. These consist are important points which to be involved in our seminar. I also thanks our mentor and guide Professor Shyam sir for enlightening us knowledge and imparting the knowledge on radiation. Thank you, sir.
Thank you, everybody, and thank you, all of those who might have joined us today. Have a good day. Thank you.